Presenting one of its kind, Dr. Haribhakti's Atlas of Robotic GI Surgery using SSI Mantra, a journey of precision innovation by the experts. Project initiated by Dr. Sanjeev Haribhakti, co-edited by Dr. Tushar Dave and Team Kaizen. Published by Haribhakti Education Foundation, supported by Kaizen Hospital and SS Innovations.
Hello, I'm describing a brief presentation on flexible needle for aspiration of the pancreatic duct in a robotic LPJ. So needle aspiration in MIS is frequently needed for aspiration of gallbladder or aspiration of cysts or even aspiration of the pancreatic duct in LPJ to identify the duct. The methods that we use normally is either the aspiration needle, which is the rigid one. Second is the direct trocar insertion, 5 mm trocar into the gallbladder or the cyst. And sometimes what we have developed is a flexible needle which we can put inside the abdomen intracorporeally and use it for aspiration and confirmation. So flexible needle identification of the pancreatic duct is the most crucial step in LPJ. Unless we can aspirate the pancreatic juice, we normally don't place an incision, and especially in a small duct disease, it is even more difficult to identify the pancreatic duct. Rigid needle here is not conducive because pancreatic duct is very deep. The rigid needle will not have a control to go there externally. An external needle cannot be controlled well, and there is a risk of injury to surrounding vascular structures. So flexible needle can be introduced into the abdomen, and the surgeon himself, either laparoscopic or robotic, can grasp it and use it for puncturing the pancreatic duct and looking for the pancreatic juice. And this is atraumatic and can be used repeatedly. So here I'm demonstrating the short video where we are using, so the stomach is lifted up with the help of a hammock retractor and a stitch combination is used, and then we get the needle inside into the abdomen. The part of this is fitted up on an infant feeding tube and a needle is fitted up. It's an indigenously created needle. As we go in, the robotic surgeon can grasp it and use it with the two hands. So the robotic grasper is now holding the needle, and then we are going towards the pancreatic duct, the area of the pancreas now. And we are now, so the benefit is that it can be curved, it's a flexible needle, and it can be grasped. There is a very good control as the surgeon is working very close on to that area of the pancreatic duct, and then there is a good retraction of the pancreatic area available. Feeling is done to make sure that what is the pancreatic duct. Of course, the CT scan and the imaging helps us. And then in an area where it is most likely to have the pancreatic duct, the needle is being pierced, and the aspiration is done from outside because part of the needle is outside, and then we try to aspirate and see for the pancreatic juice. When we remove the needle, we'll also look for the pancreatic juice, whether it is coming, whether there is some blood coming. All this is being seen, and then another area is chosen now for the pancreatic aspiration, pancreatic juice, and the pancreatic duct identification. So with this, once we are confirmed that there is a pancreatic juice in the aspiration, and then only we should place an incision under the pancreatic duct. Before that, we should avoid placing any incision on the pancreatic duct. So here we are again checking where is the area of the duct actually. So after confirming, scissor incision is placed on the pancreatic duct. If the area is not very clear, then we would prefer to open not longitudinally but vertically on the pancreas, so that to hit the pancreatic duct, the one left hand of the instrument, it stabilizes the pancreas, and then the right hand opens a vertical incision of the pancreas so that we can go deep and try to hit the pancreatic duct. I use a combination of a blunt and a sharp with forces and try to get into the duct. The robotic platform, the magnification definitely helps. The precision also helps. The movements also help. In laparoscopy, we don't have this kind of a. Now we can see that we have already entered the pancreatic duct, and then we will enlarge this pancreatic duct incision on both the sides. Thank you very much.